So I'm Fraser Burling. I'm a general physician and rheumatologist. I've subspecialised in soft tissue treatments, and I'm honoured to be chairing session 2, which is on advocacy and support. We'll start the session with a short session by me, and then followed by a panel discussion with our panellists. Each is going to be presenting on a little bit of the topics, the very broad topic that's being covered here. And we're going to have also a focus on Jemima and Rachel. Jemima is our lovely patient who's come from New Zealand with her mother, Rachel, and they are both EDS. And then following that, we're going to have hopefully a little bit more time for Q&A than our first session. So just a little brief on people we have here. You've heard about Jemima and Rachel. We've also got Jacqui Main, who's a specialised exercise physiologist and owner of Dizzy Heads & Co. with 18 years of experience. We've got Pauline Slater, who's the founder of Hypermobility Health Connect. We have Sherri Marshall, who's a patient with EDS and who's also lived the experience dealing with rare diseases and a difficult health system and fought against child protection services. You'll hear a bit more about that in our talk today as well. We have Jenny McKennariey, who's the CEO of Dynamic Capabilities Consulting, a firm that specialises in workforce compliance and creating inclusive workplaces. We have Jo Hargreaves, who's also a patient with EDS, and she's been instrumental in establishing an EDS and HSD support group in South Australia. And we have Janna Linke, who's a pharmacist, medical writer, and currently studying a Masters of Health Policy. And she also has lived the experience of EDS. So, let's get started. Is this working? We've got our slides running. Following the line of Alan, we're going to call you John. Although, interestingly, my wife has a comedy about this because she says half the world's called John. Okay, what have we got? All right. My conflicts of interest. This is our brief outline of the first 20 minutes or so. And so let's start with Jemima. She's currently 17 and she's the oldest of 4 children, 3 of whom have been since diagnosed with EDS. Growing up, Jemima didn't know she had EDS. She was more easily fatigued than her peers. She was more prone to injuries, frequently had splints or braces on sprained limbs. She could do all the party tricks, such as the splits and bending back in half, putting the head between the feet. And compared to her friends, she was often injured. She would often be at A&E for those injuries, spent a lot of time there. She was often told she was remarkably clumsy. Many of you have heard of developmental coordination disorder. This is it. And she was told that she was exaggerating her pain because there was no explanation as to why she was in pain so often, because the doctors didn't know. She often had migraines and dizziness without explanation from a young age. Sound like our first session this morning, talking about POTS? She frequently sprained limbs, which was put down to her clumsiness. She often complained about joint pains, stomach pains, and had no explanation as to what was going on. Despite that, she was a very active as a child. She's very intelligent. EDS does not affect intelligence. And if I have to say this a dozen times, I'll keep saying it. EDS does not affect intelligence. There is neurodiversity, but intelligence is not affected. She was first seen at my clinic when she was 15 years of age in November of 2022, after her mother had started looking for a diagnosis for what had been going on. She'd actually been in hospital for a couple of months, and she came to me straight from hospital. She'd been living with extreme abdominal pain, nausea. Her Baton score was still 9 out of 9, as it is now. And I diagnosed her with hypermobile EDS by the New York criteria. She'd been suffering from migraines and headaches, and we were able to dramatically reduce those with a combination of manipulative therapies and strengthening injections. It's an entire talk in its own, so we won't go into that at the moment. Not surprisingly, from those previous symptoms, she had severe POTS. It was partly due to, at that stage, we didn't know, she had May-Turner syndrome and Nutcracker syndrome. She would black out, full syncope on standing on occasion. And as she got worse, her symptoms got worse as well. She needed a wheelchair to move around a lot of the time before she ended up in a wheelchair permanently. You may see she's not in one now. The severe nausea and pain had begun when she was 15, and she'd had marked weight loss, and we saw her urgently because of that marked weight loss. She was on nasogastric feeding, but that was still painful, and while she was peaked at 32 mils an hour, that's not enough for a healthy person to live on. And even 10 mils of water or a spoon of yogurt caused her severe pain if she took it orally, and she made vomit when she was having that. She had constipation. Part of that was because food wasn't even reaching the large bowel because it was all being digested before it reached there. What was more concerning was she had a sister, Matilda, who died 8 years ago with identical symptoms. You can imagine how worrying that is. The cause of death was listed as dehydration and a suspected genetic condition, not otherwise specified. We know better now, but it was too late for Matilda. She was in hospital for a solid 6 months. She was on intravenous fluids and for a period of time on intravenous feeding as well. She had to have a central line because the peripheral veins were too fragile, and many of you with EDS will know, try to put a line in, see how long it lasts, 5 minutes perhaps, if you're lucky. Not uncommon in our EDS population group. She'd had complications of the central line with infections. So I'm going to pause here and say, what's going on? We know about the EDS, but what else is going on? And this is where I employ what's known as the surgical sieve. What is the surgical sieve? It's a way of determining what's happening with somebody when you get a set of symptoms or even a single symptom. And it becomes a filing cabinet that you can refer to when you've got a diagnostic dilemma. So what is going on? So let's show you what the surgical sieve is. So unfortunately the white there is not so easy to see. Infection, inflammation, cancers or malignancies, endocrine causes, metabolic causes, congenital and genetic causes. Many of you will recognize these. You note psychiatric's not at the top. Then there's traumatic, iatrogenic, which is doctor-induced, and drugs, because again, drugs cause side effects. And on the left-hand side where you see the sieve, you've got conditions that we have going in, which are still to be decided on, conditions which have been caught in the sieve, which are actual diagnoses, and conditions which are coming out the bottom, which have already been ruled out. And this is actually a valid surgical sieve that was present at the time for Jemima. What it is not. How many have you've been told it's all in your head? Yeah, exactly. It is not psychiatric. It is the whole list of things. Psychiatric is a part of it, and psychiatric problems are common secondary, but primary psychiatric conditions are no more common than the general population. So let's carry on with Jemima's story. She was getting worse. As I said, she'd ended up in a wheelchair, but now she was in a wheelchair continuously when she wasn't in bed, as it was too painful to stand up or walk, which is actually due to one of the underlying conditions, which we'll come to shortly. She had a loss of feeling in her legs and weakness and trembling. For those of you who know about nutcracker syndrome, it's where the vein to the left kidney gets squashed. You get a backflow through what's called the tronc-reno-rachidian vein. You don't have to remember that name. But that backflow goes through the spinal cord and can cause compression on the spinal cord. And that can cause people to have severe pain unless you're curled up in a ball lying on your left side. And if you try to stand up, it hurts too much and you get numbness, etc. Very real. Her local hospital sent her to the National Hospital, who refused to connect with our international specialists and actively blocked expansion of her multidisciplinary team. Unfortunately, this is a frustration we have to to deal with, and I know that many of you have dealt with the same frustrations. Not surprisingly, she had very low mood, especially from consultant-associated traumatisation. For those of you who went to the Dublin conference, the very first plenary talk was on consultant-associated traumatisation. Doctors not believing you, doctors not listening. It's very real. And she was also suffering from side effects of medications. The hospital told her that all she needed was a psych input and just to eat to treat her problems, i.e. the surgical serve for them was just psychiatry. Very wrong. She was told that she had pain hypersensitivity despite having scans showing abnormalities. She had private investigations which showed aortic compressions. The initial scans that were done in New Zealand showed 2 of the compressions that she had. And she had to seek international opinion from our German friends for finding further issues, which were found with the aortic compressions. As mentioned, she was unable to walk because of paralysis in her legs. She was deteriorating rapidly, and at this point, she only had a couple of months to live, if that. So, Jemima's dying. Rachel, her mum, is desperate for help for her daughter. Effective treatment in New Zealand is being denied. They needed international help. And with the confirmation of a diagnosis from Germany, Rachel and Jemima took flight overseas. I'm going to pause again now and ask a tough question of both Rachel and Jemima. Rachel, you put aside your diagnosis of EDS at the time. We sort of guessed you had it then when you came with your daughter. But you put aside the diagnosis for you because you were worried about your daughter. Someone had a question? No. You know what had happened to your daughter Matilda. What was going through your head when you had all this bad news?
I think for myself, I recognised that the symptoms that I had taken Jemima to hospital with on her 15th birthday were near identical to the symptoms that I had taken Matilda to hospital with before. I had a list of them written by Matilda's doctors that I was able to say to the doctors, look, I'm really scared, it's potentially the same thing, but unfortunately I was told it was a coincidence, it was unrelated. So that was when I started looking outside of that immediate medical team, trying to solve it myself, and found you and others.
It is definitely a network, by the way. It's not just one person. And Jemima, you saw what happened to your sister.
Yes. I think I was quite young when my sister got sick, but I remember how hard it was, not just on her, but our whole family. It affects everyone. And seeing how my siblings especially were affected when I got sick, that was particularly hard, not just the illness itself affecting me and the pain that it caused.
Yeah. And I can imagine it was hard for you when you were going through all this or yourself in severe agony. Your weight was pouring off you. I remember you came in, you were very much skin and bones. Not the worst I've seen, but you're very much skin and bones. And then you've got this big flight to Germany to deal with as well.
It was exhausting, definitely trying to not only do your doctor's jobs, but keep yourself alive.
Yeah. So Jemima and Rachel went to Germany. As I mentioned, Jemima was in a wheelchair. She was not able to walk on her own. She saw Professor Thomas Skolbach in Leipzig, who did testing with his specialised pixel flux software tests, which he helped develop, and then had confirmation of her aortic compressions, and you can see some of these on the right-hand side. She then went to Dusseldorf and saw Professor Willem Sandman at the Clinic Beletage, and she had her surgery for the median arcuate ligament syndrome, nutcracker and myothernia. Thankfully, the SMAS, her artery is on a slightly different angle, so it didn't need the same treatment for that others need. Post-op, she did actually very well. Major surgery is hard on the body, by the way. There are 20% complication rate for any major surgery that happens. That's statistics. There's nothing we can do to change that. But there are things that we can do to help improve the outcomes. However, she was walking without leg pain in 3 days, out of the wheelchair. Big wound in her tummy, and yet she was able to get up and walk, and there was no pain in her legs. The paralysis had fully reversed because there was no blood flow going back through the spinal cord that was normal rather than abnormal. By 2 weeks, she was eating ice cream and pizza. The ice cream in particular is a little parlour that Professor Sandman was telling us about that he takes just about every New Zealander to after their surgery. It's become their favourite place to go to. By 2 months, she was back home and she was able to play 10-pin bowling. This photo was taken at 4 months. Her weight had returned back to her healthy level. She had a normal appetite, still with some restrictions, but a normal appetite. She was able to go back to school and do normal activities. She still has other EDS issues. Surgery doesn't treat the other issues. But she's very upbeat mood and enjoying life again to the fullest. She's still taking medications and supplements. She still has some pain issues. We haven't fixed every problem, and we probably never will fix every problem, but the more we learn, the more we can help our patients, the more we can help each other. She still has to manage her POTS symptoms, although they're a lot less since the surgery, because the surgery was contributing significantly to the POTS symptoms. She still has some issues with gastroparesis and constipation. Rebecca's talk this morning was very appropriate. So, Jemima and Rebecca are now living life, and I want you to really recognise them as people who have been through it and really do understand. I'd like to actually give a clap. So, Rachel's since been diagnosed with EDS and commenced on treatment, much less than what Jemima had, but still needs some treatment. And Rachel continues to fight, not just for Jemima's care, but for the care of others. She's brought other patients to our clinic and acted as a support mum for them when their mums haven't been there. As I mentioned, aortic compression surgery treats aortic compressions. It doesn't treat the other EDS issues. But they can significantly improve, and when you're not dealing with one major problem, then it's easier to deal with some of the other problems. The hospital, the major hospital, still refuses to acknowledge that she had problems that were not just all psychiatric, which is really frustrating. I'm going to talk now about another mother and daughter team, Taylor and Zadie Doyle. Zadie's the mum, Taylor is the daughter. Taylor went through similar things that Jemima and Rachel went through. But they had the added problem of being referred to the Child Protective Services, or CPS. So 10 months after Taylor's first admission, the hospital accused Zadie of Munchausen by proxy, saying that making it all up and creating the symptoms. By the way, Munchausen by proxy is about 4 per million, but in New Zealand you'd think it was 4 per 100. It's actually still 4 per million. 2 weeks prior to Taylor and Zadie going to Germany, the SIPs tried to block their travel. And it took 9 months of advocacy and lawyer help before SIPs finally backed off, because they were wanting to take away not just Taylor, but all of Zadie's other children as well. And these are photos starting off from 2021 through to 2024, where Taylor is now an advocate for many people as well. And Zadie is a major advocate working with Rachel. So, aortic compression surgery, it's not a bed of roses. As I said, it has a 20% complication rate. And aortic compression surgery is no different to any other major surgery. But every one of my patients who's been to Germany and had aortic compression surgery is still alive and many would not be if they hadn't been, and they are much better. Doesn't mean they're fixed of all their problems, but they are much better than what they were, and they're able to sustain their weight and not be losing weight. For those who need it, it helps. For those who don't need it, don't go there. It doesn't help at all. So you have to select who goes. And you will still have the other problems post-surgery that you had pre-surgery, although some may improve, you'll still have those problems. And I've heard of some people in Australia who've had surgery in Germany and come back and haven't done well because they haven't had these other issues looked at, such as the gastroparesis or small or large bowel disinfertility, or the mast cell activation syndromes, or the dysautonomia in POTS. But they're easier to treat when you haven't got one of these major issues going on. And for our patients, it's a case of working through and saying, what is everything causing the symptoms? The surgical sieve doesn't necessarily have to have one diagnosis. Even though we've got the overarching diagnosis here of Ehlers-Danlos syndrome, there are all these other issues that are present, and we need to look at all of those problems. So if a person has had surgery, whatever the problem, for whatever the problem is, and they're not improving, go back to the surgical sieve. And if you've got a colleague or a doctor who is not considering the whole surgical sieve and thinks it's all psychiatric, then you need to introduce them to the surgical sieve. And ask yourself, who's missing on your multidisciplinary team who needs to be brought on board to help you answer these questions? So, if your multidisciplinary lacks a local or national expert, where do you go? International experts. And guess what? The Ehlers-Danlos Society has a long list of people who are willing to help. If you're a doctor or in allied health and your name's not on that list and you're passionate about EDS and helping people with EDS, please submit your name. We want you too. We want you to help as well. We want you to be part of our team. Yes, they'll check you out to see that you are passionate about it, and if you are, they will add you to that team. Then we have the International EDS Echo Series. The last meeting of that was yesterday morning at 3 a.m. Brisbane time. Sorry guys, I missed it. I slept through it. I normally get the New Zealand one, which is about 6 o'clock in the morning in summer and 4 o'clock in the morning in winter, but that's okay. It's part of what we do to stay up to date. Then there's the Australasian EDS Echo Series, and the next one of those is in 2 months, about 2 months, yep. And that's a session that has been going on, and we had 3 sessions last year, another couple this year. Very, very useful ways of networking and learning. And even though I'm there now as a help coordinating, I learn something every session. There's always something we can learn. Then we have meetings like this one, patients and health professionals networking together, which is really, really important. We've got the EDS international communities on Facebook, Instagram, TikTok, etc. I don't know them all. There are some people here who know far more than I know about those. I know I'm not tech savvy like some people. That's fine. Everybody has a place. Everybody can help everybody else in some way. Rachel with Zaylee run a compression Facebook group. And Rachel, Zaylee, and another mum, Jo, whose daughter died 5 years ago from starvation. Unfortunately, I only saw her 2 days before she died as my first consultations, the only time I've gone and done a home visit, because her weight was so low, she was just skin and bones. But there's now Ruby's Voice page, and Jo has joined together to help fight to get EDS recognised in New Zealand at parliamentary levels. And then we have our centres of networks of excellence, and you've already heard about some of those this morning. So, how do we counter the negatives? This is not easy, it's not fun, it's hard work, and it's stressful. But you need to encourage the consultants who think it's all psychological to consider the whole surgical sieve. If they still don't, then you have reason to make a complaint. And again, making complaints is not fun or easy. In New Zealand, we have the Health and Disability Commissioner, and you'll hear a little bit more later about others in Australia. And there are resources online to help direct you as well. One complaint may not get far, but multiple complaints can start to make a difference and do. You can call, write to your local MP or even Prime Minister. You can make submissions as a group or as individuals or both. And ensure that your government realises that everyone, including the Indigenous populations, and I say that because sometimes they focus more on the Indigenous populations than on the general public, but you have to make an emphasis on what they're going to listen to so that people aren't being damaged or worse, killed. I use that term killed because it's the reality, by the bad decisions being made by the doctors who deny the surgical sieve. So we need to be positive, be proactive, be proud to be a zebra, because as zebras together you dazzle. And most importantly, be supportive. We as doctors need your support just as much as you need ours. Now I'm going to pass on to Jacqui.
How do we work this thing? Here we go. So today, as Fraser introduced, I am an exercise physiologist. I live with the conditions and was blessed with a beautiful little boy 5.5 years ago who, as you can see, lots of my genetics came out pretty strongly from birth. So I'm here today more talking about and I don't like to say burden, but it's the challenge of what I've been through as a caregiver, as his mother, as his advocate. And even though I'm a health professional and working in this space for so long, I have still felt challenges in finding the right pathway, the right care. But as Fraser was just talking about, that fear of being labelled, that I'm making it up and all these sorts of things. So I didn't expect what I now have now, but I didn't assume the worst. But as you can see, my little one was born with positional talipes, but with my knowledge, thankfully, I was able to get him some care for that within the first 2 weeks of his life. So just having my knowledge made me more observant. However, I was still quite fearful because of the gaslighting I'd been through myself for many, many years. At 6 months of age, he was admitted to Monash Children's Hospital in Melbourne just due to bronchiolitis, but fortunately, we had an amazing paediatric emergency doctor that night who queried some of his milestones and why he hadn't achieved those and a few other issues. So that's when things really started to be supported and I felt heard, which was really important for me. So hip dysplasia, we're at 6 months of age, starting feeding when he couldn't actually grip anything with his hands. He had adducted thumbs across his hands and he spent quite a lot of time in splints, which was very hard. That then initiated a feeding speech pathologist because he also had high palate, then narrow top jaw, wide bottom jaw, low facial tone, as you can see, just his sitting position, he hated tummy time, couldn't hold his head up. So all of these things were just starting to make more and more sense in my head as he got older. So we had some physio and occupational therapy at the local hospital, but for better care, I decided to take him privately. And we did have a paediatrician, but he told me that he will grow out of it. And I thought, well, I knew that wasn't true, but I didn't really know where to go to next because I thought if that's what one paediatrician was going to say, well, where do I go next? But fortunately, the outpatient OT put us onto a paediatrician who's also a rheumatologist. And then we also found out he's a very marfanoid feature type little boy as well and has an increased dilation of his ascending aortic arch. So we have cardiology and everything else involved as well. We've been through genetics. And I felt really lost coming into COVID times, and it was thankful to attending a Facebook Live with Ocean Kids Health in Melbourne, and I started working with the team there, and 5.5 years down the track, we still work with this amazing team. I don't know where my son would be without that team. What is still going on is, he has excessive hypermobility and he still has these retained primitive reflexes, and I feel this is something important to mention today because it was even just recently an Instagram post that I saw of how this affects kids' fight or flight, particularly the Moro reflex. My son Hargreaves is still 4 out of 4, so that fight or flight reflex, poor manual dexterity, poor hand-eye coordination, retained ATNR, so tactile proprioception, sensory issues, he gets car sick all of the time, and then his spinal gallant reflex, which is around incontinence, we've been struggling with for so long. Digestive issues, he's always chock full of poo, and without Movicol, I don't know how we would get him to survive and be able to eat the way he does. Thankfully, we fought. He's on the NDIS, but these are these ongoing issues now. He has still quite a large separation of a diastasis. You can see some of the marfanoid pectus. He has really horrible thermoregulation. It's very hard how they're managing him. He started prep last week. He didn't walk until he was 18 months old, and this is just some of the fun and amazing work of Ocean Kids Health and things like that. So we can see that global developmental delay, but I just kept pushing and pushing and pushing.
Jacqui,
yes.
Should we just pause at the moment and put up the Slido questions?
Yes. I'm guessing the team will do that.
So the first Slido question is, what was the first sign or symptom that worried you? As people, when you're listening to this story, what would have worried you? And this is a word cloud one, so just put on 1 or 2 words that you would be worried about if you saw this in your own family member. John, can we have the Slido question briefly put up to get the word cloud, please?
His name is Bryce.
Okay. We've got the Slido word cloud. Yes, and a lot of really good, important points coming through here on that word cloud.
Yes.
Things that would be worrying me as well as a doctor listening to this. They are all very important points.
Yes, the delay in walking, low muscle tone, ENT issues. Harvey's had grommets, adenoids, tonsils, all done very early on. Podiatrist, feet issues, clumsy, falling over all the time. He's covered in bruises. And again, that's the fearful thing for me is, somebody thinking I would ever hurt my child with him being covered in bruises. It's something that I always feel I need to declare, that it's like, oh, he's clumsy, he falls over, he bruises, he has this condition. So, that's what goes on within a mother's head. Oh, that was his walking. We can see a very wide gait, and just the joy of some of these things that, makes it a little bit easier as a mum. He had a developmental regression, unfortunately, around August 2023, neuropsych assessment. But not surprisingly, we know the link between these connective tissue conditions and neurodivergence. So he's been diagnosed with autism spectrum disorder. But the main thing at the moment is, since then, is this obsessive repetitive running, and it's still very much a question of, is this proprioceptive deep sensory seeker, which he is. He loves a cuddle. But he stopped playing with toys, didn't want to leave home, a bit of anxiety and things like that. So many of his systems are in that sensory overwhelmed way, and at the moment with him starting prep, this is what they're saying to me. He's spends more time outside the classroom than in what he does inside. And this is where I'll leave the education system type talks to my colleagues here, but it's with everything that I've been through with my little one and going forward, it's been really hard how to choose where for him to go. Where's he going to be supported, understood, the additional support that he needs. The paperwork is never ending. It's a full-time job on top of what I already do. And the funding systems, they need to be better for our kiddos because there's so much that goes into it. He is in a mainstream school but specialises in these types of conditions, and they are so open and willing to do anything and everything that they can, working with our external team. So I'm very grateful and looking forward to how he will go in that system. So we've got another quick Slido question before I will hand over.
Why don't we just put that up while Pauline comes up next for her next part.
Thank you, Jacqui.
Thank you, Jacqui. It's wonderful.
While that Slido question comes up, I'll just introduce myself. I'm Pauline Slater, physiotherapist. Somewhere in the middle there I did a teaching degree, so have done both, taught at primary school level and working through paediatric physio into adult physio because my paediatric clients grew up and there still was no one to see them. So we moved through the spectrum of life. The question we asked was which of the schools do your child attend? Many children are in mainstream schools because, well, Australia actually does have an excellent mainstream education, but there are many children who do attend specialist schools, be that privately. Pardon? So we didn't ask homeschool. Many children attend homeschool or any varieties of schooling to just get through. So yeah, I run Bendy Body's Physio and about to do a thing called Hypermobility Health Connect, and really impressed that children actually are able to access our education in our country, and with the right supports in place we are actually able to get our children through the school system and survive. My family, both children have all of these syndromes, and I now have one at university thriving well, so we can get there, and I have many patients who've made it through. So it can be done with a lot of hard work, persistence, and, as someone said to me, bloody mindedness. Okay, factors in choosing school systems. This is another Slido, but this is obviously just a list that I'm going to put up because we know there are many, many choices that have to be made. From the medical ones, when you're looking at children who are extremely medically susceptible, when you've got a child with classical EDS, to all the other, just day to day, how is a child going to survive in a school of 900 children versus a school of only 60 children? These are the choices as parents we make. And even as a parent who is a teacher and a physio, I have been labelled every single label under the sun, particularly the tiger mother with Munchausen by proxy. Yes, love that one. So I hold that one proudly. Yeah, many, many reasons why we choose the schools we choose. So my talk today is just around advocacy and supports, and with our dedicated 6 or 7 minutes that we have, I'm going to just touch the surface throughout the education journey, be that from preschool all the way through to university and beyond into TAFE and in there. So children with differing abilities have the same rights in this country and in New Zealand and around the world to access education like every other child. It is their right and it is their absolute privilege to be able to reach their optimal levels of potential, and it's our job, with those of us who've got the knowledge and the skills and the bloody mindedness, so to put it, to see them through. This is just a list of the possible laws and acts that can support you. This is all going to be available later. I am not going to list them all now because there's much more important information to get through, but there is every type of act that exists, from that Disability Discrimination Act all the way through to inclusion support programs in universities and TAFEs to make sure your children are supported all the way through their lives to reach that and access that education that they deserve and should be able to access. So beginning in primary school, beginning in preschool, we asked that question before, what are the first signs and symptoms? And I spend a lot of time going into schools actually, and preschools and high schools and universities, talking to people about hypermobility and how it impacts the education journey. And the first question I'll ask when I sit down with teachers is, and I do appreciate teachers have an extremely difficult role. Many of them have got 30 plus children in a class. Many of them have multiple children with multiple health issues, cognitive issues, intellectual issues, social and emotional issues. They have to manage on a daily basis, along with all the curriculum they need to get under their belts. Teachers are often very surprised when you mention the stats on hypermobility versus autism and ADHD that they all have to know about. So we always bring that one up first, and staff are always interested to find out how many people on staff actually do have hypermobility and actually have some of the syndromes we're talking about here this weekend. So we know what we can see in the classroom and what teachers will see, and they will blame it on many other things. So most of all, and the one that I hate the most, is a child that is lazy. It breaks my heart as a teacher, as a mum and as a physio to hear that. Because most children want to learn, most children want to engage, most children want to have friends. Most children, as Fraser said, they are all intelligent. EDS hypermobility does not in any way, shape or form diminish a child's intelligence. But we need to help schools understand better what's going on and why. And that's our role. When you're working in the school system and with the school system, it's really important. I think we're talking about every type of EDS this weekend. Emergency planning in preschools, in primary schools and high schools is extremely important. That all staff at all levels who may actually interact with your child, be it from playground to the bus stop, to the staff that deal with the office first aid, need to understand an emergency plan for children of all types, for all varieties of issues, because every child is going to be different, as we know, as HSD and EDS presents in so many unique ways. So, first and foremost, in any situation, children will not be learning and won't be able to learn if they don't feel safe in their environment. And emotional safety cannot be underlined enough here. The number of times I have children who not only have I been into schools and spoken with staff, where they still aren't heard, their POTS is still not believed, their EDS is still not believed. They have to get up from their desks having tachycardia to get attention of the teacher so they can get the nurse into the classroom. So children need to feel safe or they're not going to learn, hence the why children are homeschooled. Children need to feel safe or they will not be wanting to go to school. They're going to be wrapped around your legs, as both my children were most of their schooling life in primary school till we got diagnoses. In a classroom, children need the capacity to be able to access teachers that believe them. It's bad enough that they're already through a system where their parents and themselves have not been believed in their symptoms, but that their symptoms are diminished again at school once again removes that aspect of safety for them. So having strategies in place that are verbal or non-verbal for a child to be able to access and say, I am feeling, without necessarily being the standout in the class, because children don't like to be the standout in the classroom at all. They need to be able to get their message across to a teacher to say, I need help. Many children develop a doctor friend or a nurse friend in the classroom, and I often engage children in presenting about their own illnesses in the classroom. That way they actually have a class that understands what's going on for them. So children in the playground become that child's advocate. And that can be their biggest support weapon in the school system if they want to stay in the school system. And very important for any primary school is understanding the use of prompt cards. So I need to use a toilet, I need to leave now, I need a safe space, I'm very tired, I need to see the nurse because my heart is racing, but they can't say it because they're actually shutting down. So all of these systems need to be put into place. How do we put them into place? We put them in place by using the IEP or the ILP, which is a requirement in Australia for all children with any type of emotional, physical, psychological, cognitive, or combination of those types of abilities, disabilities. These are required. They will not happen, though, magically, without you asking. They are going to require a very dedicated, consistent approach where you define your learning team at school. Every school has a learning support program. I encourage you highly when you engage with your learning support team, officer coordinator, you CC everything to the deputy principal and principal. Principal has to sign off on every learning plan. So it's important they know from the get-go they have children in their school that need this help, that they're part of the conversation. This conversation involves not just understanding what your child needs as a specialty in terms of the areas of their challenges, but your child will have strengths. They have amazing strengths and amazing capabilities, and they're the things we want our children to shine in. So we want to make sure that is part of that overall IEP. Setting up goals that are very smart and specific. So specific, measurable, achievable, relevant, and time-related. And as their caregivers and advocates, monitoring their IEPs, 3 to 6 monthly, if not every term, at least 6 monthly. And on some occasions when I've had children tell me that they're being invalidated at school, I make sure that the school is rung once a month, because we want to make sure those children aren't standing up and fainting in the classroom, because it's the last thing they need. Teachers are required now by law through NESA, the Education Association here across Australia, and unfortunately we have several educational bodies in every single different state. We don't have a federated education system, but teachers are required in every learning plan to put in accommodations and modifications that will optimise a child's learning, and they need to be put in very specifically, so those goals are extremely important. And as I mentioned before, revisit that IEP every few months. Many IEPs can be put in place to the point where you can say, no, my child does not need to be doing music, my child does not need to be doing languages, my child already has dyslexia, autism, HSD, they just need there to be there for the basics at this point in time, we will homeschool them for the rest. Many things can be done. Really, really important, UNICEF brought this one out a few years back, regardless of the education levels, primary, preschool, university, children with disabilities are more likely to be out of school than children without disabilities. And when you start to look at the combination of functional disabilities then and or overlapping with anxiety and depression, which unfortunately is part and parcel, be it doctor-induced, physio-induced anxiety, depression, trauma, and or then school system-induced trauma, they are out of school more and more and more as they progress through the education systems. Many times schools will flag you as being the parent who is negligent and not sending their child enough to school. Even with paediatrician reports, rheumatology reports, physio reports and those sorts of reports. And this is where we develop thick and thicker skins. And we just keep advocating and advocating. If you need more information, please see the resources. We have resources packages. You find those of us online at in the EDS Society who are both physios, OTs, educators, teachers. You'll find us there. The HMSA have an amazing education support site which provides lots of information about modifications and adjustments that can be done in schools and packages through the School Toolkit. The EDS Society does, as does POTS UK. And most importantly, having a team and well-monitored individual learning plan is key. And it's key from prep all the way through to university, because they still have learning support people there as well and into TAFEs. Making sure that everyone is supporting you and your child to access that equitable education, it's just absolutely essential. And that way children actually have a chance to reach their optimal outcomes rather than doing the I hate school and I'm dropping out and I'm leaving, which is what happens so many times. And it can be avoided because there are so many ways to do school. It's not a one system fits all. We are all different. Children are all different. School systems just need to be brought into line with that a little bit more. I'll leave with you this last phrase that I absolutely love. Everyone is a genius, but if you judge a fish on its ability to climb a tree, it will believe that its whole life that it is stupid. And it makes me cry when children say that to me. But with all our help and with ongoing education and research, we will get there and we will support these children through their journeys. Thank you. Who's up next? Sherri.
Good morning, everyone. My name is Sherri Marshall. I run the EDS Australia National Support Group based in Melbourne. I'm a patient, parent, carer and a retired teacher. This morning I'd like to talk about medically fragile EDS children. It's a topic that might cause grief for some people, but it's very important and something that all parents and medical professionals should be aware of. You can access more information in my resource package afterwards, and I'll be showing you very briefly some strategies that you can use to help children and teenagers with EDS. So sadly, EDS mimics child abuse. Doctors are trained to look for red flags or alerting signs of child abuse. And usually that's a good thing, but unfortunately those red flags are also signs of complex rare disease. So if you have a child with multiple symptoms, such as bruising, broken bones or gut issues, and you're asking for pain relief, questioning doctors or complaining, you're too familiar with medical terminology, doctor shopping, advocating for more tests, or trying lots of different medications, sound familiar? Then sadly, there's a high chance you will be either accused of seeking drugs, accused of a psychological disorder such as fabricated or induced illness, accused of medical abuse, reported to children's services, and even have your children taken from you. Wrongful allegations are increasing, and sadly, usually against the mothers of children with the worst symptoms of EDS. So why is this happening? Mostly because of lack of knowledge and education, under-resourced medical systems, delayed diagnosis, and over-reliance on psychological labels. The use of unsubstantiated profiling and alerting signs, opinions, and likelihood. Lack of medical evidence of criminal standard and cultural issues such as the abuse of power. However, looking at the signs, odds are it's a rare or genetic disease. The incident rate for rare disease is 40 in 500. For EDS, it's 1 in 500. For a factitious disorder in another, 4 in a million. When doctors get it wrong, unjustified allegations against parents come at a dreadfully high cost to children and families. I've provided support to more than 10 families in the last 5 years who have lost custody of their children due to EDS symptoms leading to wrongful allegations. I've worked on cases where the child already had a diagnosis of EDS from a professor of genetics, but it was overruled by the hospital. Thankfully, I have access to legal advice and fabulous doctors and great resources, but most parents cannot afford legal representation on top of their medical bills and are often forced to represent themselves without any legal assistance. Because these cases involve children, they are held in closed courts, making it very hard to obtain data or ensure accountability and transparency. You won't see them in the media. You won't see these reports on social media. Parents are gagged and treated like criminals. The use of medical opinion in such cases is gradually being superseded by demand for scientific evidence and the involvement of geneticists. I urge you to watch a new documentary being released soon. It's titled Complicated, which deals with these very issues in EDS families. You'll find a trailer on YouTube. My own daughter suffered horrendous medical harm, treatment denial and trauma after I was wrongfully accused of Munchausen syndrome by proxy when she was 12 years old. She was born with dislocated hips and she developed EDS symptoms in the first 12 years. At age 12, she participated in slip and slide. She broke 6 ribs and caused 2 bilateral Spigelian hernias. It all went undiagnosed by our regional hospital, and psychologists wanted to admit her to the psych ward for 12 months so she could learn to live with pain. They were missing something, so I sought other opinions. But this is when I was accused of Munchausen, because I was allegedly doctor shopping, requesting pain medication and forcing her to use a wheelchair. 8 months later, a surgeon in Melbourne discovered she had Spigelian hernias. 10 years later, we found out she also had broken 6 ribs. Children's Services contacted me, but by then we had a diagnosis and a treatment that worked, so they dropped the case. But the false allegations remained on her records and affected all her future care. Records cannot be removed. They can only be updated, and the stigma sticks forever. I was not made aware of the wrongful allegations, so I didn't realise why most of her ongoing treatment was so appalling. until I applied for the hospital records a few years later. She finally got a diagnosis of hypermobile EDS at 16, but because of the allegations, her care did not improve. She was labelled a drug seeker and seriously emotionally retarded in her hospital records. She was frequently denied essential treatments for pain, infection and allergic reactions. Many ER doctors refused to relocate her dislocations. She had over 100, 5 in one day, 9 in 1 week, because they thought she was a drug seeker and doing it on purpose. Once they even called the police to have her removed from the ER without relocating her shoulder. So as a result, we were forced to move our house, sell our house and move to Melbourne to seek better care. But the false allegations followed her and further affected her care. She was left for 5 days with a dislocated shoulder because the hospital believed she was a drug seeker. She was physically removed from ER by security guards who dislocated her shoulder in the process. And over the next few years, her condition deteriorated and every symptom was misdiagnosed as a psychiatric condition, including gastroparesis, hemiplegic migraines, non-epileptic seizures, and she developed medical PTSD. She was diagnosed with anorexia and told there's no such thing as MALS, and she suffered in agony for 4 years, requiring a GJ feeding tube. She was finally diagnosed by a private specialist with MALS and nutcracker syndrome. She had surgery. It was a very long 2-year painful recovery, but now she no longer needs a feeding tube. She's eating normally, she's put on weight, and I'm happy to say she's pregnant. But the consequences of the false allegations and the treatment failures were really very traumatic for my daughter and the family, and the cost, both financially and emotionally, has been devastating. So this is why it's my passion to improve care for EDS children and young adults, and we learned that having wonderful doctors and medical plans can help you avoid the effects of false allegations. So thank you for listening to my talk, and we're just going to put up another question now on Slido.
We'll just actually pause that question, we'll ask it directly, and that is, have you or your child received an incorrect psychological diagnosis? Just to a show of hands, because this is an interesting thing that is actually, it's not uncommon at all. So for the sake of time, I think we just need to move on to the advocating for helping you advocate.
So there's strategies for how to help you manage EDS children and to avoid those false allegations. You'll find them in the resource package. So it just talks about how important it is to get the correct diagnosis, and if you are struggling with that, please, you might need to see a geneticist. There's also strategies for EDS children at school. So there's a lot of information there you can access in the resource page. There's also strategies for teenagers. So one of the examples was my teenager driving to the shops and she dislocated her shoulder on the way, just drove herself to the ER, and the doctor said, oh, well, maybe you shouldn't be driving. So, and you know, slip and slide was lots of fun, but I broke 6 bones and had 2 hernias as a result. So there are some things that you might need to consider in the management of teenagers who just want to go out and experience life and have fun. One more Slido question. Have you restricted your child's or your teenager's activities because of EDS? And did you find the symptoms worsened during the teenage years because of the changes in the hormones, and particularly in females? So there's a lot of things to consider in teenage years. So the information is there for you to access later. And we thought after that heavy topic, you might want to have a little stretch and just say hi to the people beside you, and then we'll move on to the next person. Thank you.
Thank you very much, Sherri. While everyone has a minute to stand up and stretch, we're going to have Jennifer come up to the lectern next. Just up on the...
Oh no, Jacqui's got them.
Okay. You can take a minute to sit down, but if we just bring the noise levels back down again, we'll get right on to the next part. Thank you, everybody. So, and thank you, Jen.
Good afternoon, everybody. I'm Jennifer McKennariey, and I live with hypermobile Ehlers-Danlos syndrome, which was diagnosed after 28 years. And EDS, we know, is an invisible condition, and it's often misunderstood, and that leads to a lot of stigma and subsequently a lot of challenges for patients. So today I'll share some insights into stigma, addressing some of the aspects of EDS with more empathy and workplace accommodations that can help support EDS patients. So this is all based on my personal experience and professional insights as an employee with EDS, as someone who's worked in the healthcare sector as a consultant, working on clinical solutions and patient pathways, and as an employer and a specialist in workforce compliance. So when we're looking at the stigma around EDS, if I can get the slide across. Yep. There we go. So looking at a lot of the stigma around EDS, we find that it does stem from a significant lack of education and misconceptions, and that can create a big cycle for EDS patients that can ultimately worsen symptoms for patients. And so some common sources around stigma around EDS will include the misunderstanding of symptoms, and patients often hearing, "You don't look sick." Look pretty good. And with the frequent invisibility of the conditions, and someone like myself who often won't be using a visible aid, people often doubt its legitimacy and the seriousness. And there's often a fear of liability and inconvenience with patients being seen as high maintenance or unreliable. So if we jump over to the Slido poll, we've just got a quick question around stigma and want to hear from people. What do you think is the biggest contributor? We've got, there we go, lack of education. We've got the stereotypes around chronic illness, miscommunication, or a mix of all of the above. And for me, I think a moment that reflected both the stigma and a lack of education was the clinical education aspect when I was hospitalised for IV antibiotics, completely unrelated to EDS. And the doctor that saw me in from emergency actually said, "So what's this EDS you think you have?" Amazing opener for relationship building. So I'm sure others have had varying different experiences, and I think we can see that there's a pretty mixed bag of what people have experienced, but we can probably reflect on each of those contributors. So thanks for sharing your thoughts. Keep jumping in with what you'd like to add into the poll. But the stigma around EDS, when we're looking at it, it does manifest itself in a lot of different ways and dependent on the different settings. So in social settings, we see assumptions of laziness, about avoidance, or just exaggeration. At workplaces and schools, we face doubt about not only our reliability, but our capability. And we know EDS patients are not limited when it comes to capability. But for patients, those misjudgments can really be exhausting and demoralising, and they erode trust and they hinder collaboration. And that can result in limiting our disclosures around our condition and assumptions that it's not as severe or needing additional support. So when we're thinking about it, if I can get that one across, the upshot of, I guess, practical points that we can look at is making some small shifts in language that can make a really big difference. It's a simple thing that we can all do. And our clinicians can support this. Approaching EDS with empathy, we've included some of the questions and some different ways you can reframe common misjudgments that can just slip into conversation unconsciously without realising it. Essentially, with clinicians, validating our struggles and empathising with patients can help to reduce stigma. And asking open-ended questions and helping to focus conversations on functional limitations and the impacts can also help with this. But patients may also benefit from support to equip them with the right language and tools to explain their condition in social settings. So promoting empathy and improving that communication can be a big thing for patients, and that can help with gaining additional support for accommodations, managing the symptoms and the impacts of EDS while also maintaining privacy. And clinicians can help provide that support and direct patients to resources such as conversation guides that can provide a bit of guidance in that sense. And addressing stigma in social settings, it's important to recognise that patients do receive different levels of support from their families, from their social networks and from their communities, and it can be highly variable. So practical tools, a good one can be a standardised to whom it may concern letter. From your clinician can help patients navigate some accommodations across work, across schools and across public venues with dignity. That can really be helpful in the moment when it can be a little bit more challenging to find the right words to address some of the stigma that you face just out in the big wide world. So sharing some of those case studies, education campaigns, that'll help improve the awareness. And even something like TikTok videos, there's some great EDS patient and clinician TikToks, helps get a lot more cut through with different audiences, a lot more approachable, a bit more fun, more interesting than my fact sheets. But using those tools that are out there to help have different conversations and create awareness can help address it. So at school and work, we do find that there are a few differences with patients often experiencing judgment around just requesting support. So making it more approachable, and we can do a lot more to advocate and normalise accommodations as productivity tools and not burdens. In our clinical settings, we can advocate for improved and more standardised clinical education on EDS. It is highly variable, the level of education and exposure to EDS information that we've seen. And that includes more awareness and accessible clinical resources on EDS and the common comorbidities that we see, like mast cell activation syndrome and dysautonomia. And for patient privacy and disclosure, remembering that when advocating efficiently and effectively for your patients, that details about the patient's condition can actually remain private and only the necessary information disclosed. So focusing correspondence for patients on the functional limitations, not including details of diagnosis or symptoms, that can really help with protecting patient privacy. And using standardised templates for wording for patient correspondence can help with maintaining that, particularly when it's required for employers. Moving on to workplace adjustments and accommodations for EDS. Some of the common practical examples include flexible working hours and accommodations that are like ergonomic aids, but exemptions from frequent medical certificates is also a good one. Policy changes that are normally typical run-of-the-mill things that can add additional pressure to people. Clinicians can help support patients with this and communicating those needs. And each individual EDS patient and accommodation need is going to be different. There will be different variables from an employment perspective that need to be considered. And around eligibility, but providing the accommodation shouldn't be viewed as a burden. There are numerous benefits to making accommodations for EDS patients, not just for the individual, but also for businesses and the broader economy.
That's all right, good. Thank you.
And when we're talking about it from an Australian standpoint, there is a lot of legislation that we have for providing adjustments, making accommodations for medical conditions like EDS. Similar legislation exists overseas. However, despite this, we haven't seen a bigger increase in workforce participation with people experiencing these conditions, which says a bit for the accessibility. So as for the process to request accommodations in workplaces and schools at a high level, the process remains the same. It's fairly consistent, however, we each have different roles, and patients can collaborate with clinicians and multidisciplinary care teams to help conduct functional assessments, identify needs and advocate for further support and accommodations. There's funding options that also exist. We have Australia's Employment Assistance Fund, which helps employees and employers with the cost of workplace accommodations. Similar funding does exist elsewhere, but we need to see more of these around. So creating inclusive spaces, it isn't just about the policies and about the paperwork side of things, it's about the people. And as I said, EDS patients are incredibly capable with the right level of support. And they're not just nice to have, they're actually transformative. So the stigma and accessibility goes hand in hand for accommodations. And addressing the stigma around EDS, we can create more inclusive spaces for patients to thrive. So along with this presentation pack, we've got additional resources for download to help support people in taking the next steps. And thank you for everyone for being part of the conversation.
Okay, hi everyone. So I made a deliberate choice to talk about the importance of our stories in advocacy, and then I immediately thought, what the bleep? How am I going to do that when on most days we really feel like that nobody is listening? So to help understand that, I've chosen to share this wheel of power. It's going to be a bit of a theme through my talk. And I know that you probably can't see the detail on this, but what you can clearly see is where those of us navigating life with a chronic, complex, largely invisible and probably undiagnosed condition sit, amongst a system where people and organisations with resources and power are influencing our everyday. We don't have to look far to see how that's currently playing out in global politics, but also there is definitely not one ring to rule them all. This visual can be used in several ways. Looking at our own lives in relation to power, noting it's dynamic and things change, but even if you're navigating that out a wheel, how much energy it takes. We can also reflect on how it feels to place ourselves in other areas, but then the obvious question, what stereotypes might come to mind as we reflect on areas that we have no experience of. So our stories are unlikely to change deeply embedded assumptions, but our stories do build knowledge and educate, and this is powerful, especially for a community that is sitting so far outside that inner wheel, with sometimes confronting but also vital information to share. So it's for that reason that the strategies I've offered for effective storytelling focus on purpose, consent, connection, and pacing, with two key aims in mind: creating impact and protecting our own well-being. I stepped into advocacy at the age of 42 when I finally got my diagnosis. My whole year was an negative experience of power, and probably the worst that happened was when in 1983, at the age of 16, I found myself alone in a room with a man that did something that was not needed for any kind of diagnosis. So when my diagnosis did come of hypermobile EDS, it was with the positive experience of power that came from this community that made the most difference. And we've all experienced this. Even the smallest acts of visibility unite and bring power to this whole community, where and when we need it most without even realising it. So it's through connection where we do find clarity and know that we are not in this alone. And while our stories and advocacy are important, as I've said, this should never be at the expense of our own well-being. And here I want to shout out the amazing work of Rare Voices Australia. There are now resources to ensure that health professionals understand our unique wellbeing needs, including the impact of diagnostic delay and the grief that comes with this. And there are also a useful guide for patients taking us through the range of digital wellbeing supports that are available here in Australia. I was fortunate enough to be involved in that project, and I can assure you that the needs of our community are very well reflected in those resources. And when it comes to community advocacy, have a plan, be patient, be persistent, and be flexible. And I know we can all achieve that goal. It really does all pay off in the end. every single person educating health professionals along the way, as frustrating as that might be at times, gives power to the rest of us. Every single medical professional becoming EDS aware is sharing their power by taking us with them. And every story shared amplifies all of our stories. And this can be powerful enough to change practice, to change policy, and to ensure that we're not only opening those doors, but we're leaving them open for the rest of us that come behind. And also use the toolkits and resources that do exist if you are stepping into advocacy. The Taking Action Together toolkit is an example of how Australian rare disease sector has worked effectively together to speak up for systemic change. And we still have a lot of work to do, but there are many smart and good people who are changing inflexible and outdated systems that don't work because they were designed for too long by people in that inner wheel without us. So, to finish, this quote takes us back to the question I posed at the beginning, demonstrating the danger in stereotyping. And you will all recognise it. It's one of the most common threads woven throughout many of our stories. Thank you.
Hi, everybody. My name's Janna. I'm an EDS patient, a pharmacist, a medical writer, and one of the founding directors of Connective Tissues Disorder Network Australia. I'm talking today about national level advocacy, what this is, how it can look, and who can get involved in it to lead to systemic, system-wide improvements. There's one aspect, though, of this type of advocacy that's key or critical to the success, and it's the adequate and meaningful engagement and involvement of community. So, what got me here to speaking with you all about community engagement for the EDS community? For the most part, it's been my own journey, and then hearing the journey of others along the way. I was diagnosed in 2018 with EDS at the age of 32, despite a lifetime of symptoms like many of us. I have severe basilar invagination and upper cervical instabilities, and of course this is just the tip of the iceberg. Since my diagnosis, I've been advocating for awareness for EDS and the wider EDS community, to raise awareness and understanding of the gaps in care that exist and the diagnostic delays that we all too often encounter. I think it can be said, and we'd safely all agree somewhat, that we are one of the most disenfranchised patient groups there is. These headlines and snippets are from media articles I've written or been involved in over the years, all with the central aim of raising our community voice. So, Slido question, have you been involved in community engagement? Has that gone to the Slido? We'll let that go through to the poll and I'll move on.
Let's move on.
Raise a hand, we'll move on, yeah. So, realising, though, that in Australia we lacked coordinated advocacy efforts that were focused on having a national level and systemic impact, my advocacy changed course. Myself and a core group of fellow patients and carers came together in late 2022 to put the wheels in motion to establish ctDNA, an organisation that's wholly focused on amplifying the voice and plight of Australians impacted by heritable connective tissue disorders. As we know, HEDS and hypermobile HSD and HEDS is unlikely to be rare, and the impacts could be as high as 1 in 500 or more, such that the largest cohort ctDNA represents and sets to help is those with HSD HEDS and the other subtypes of Ehlers-Danlos syndrome. Importantly, one of the first actions taken when ctDNA incorporated in early 2024 was to become a member of the Ehlers-Danlos Society Global Alliance, something we value hugely. Further community engagement has included developing and fostering key partnerships, for example, with leaders of social media, support groups such as Joe and Sherri, who are here with us also, engagement with Ehlers-Danlos New Zealand, the organisation over there, and the society. Engagement with other formal patient advocacy groups supporting comorbid conditions has also been really important. Valuing the importance of community represented. It was critical in the early days for ctDNA to set up subcommittees. So we have our lived experience advisory panel set up, as well as a really robust scientific and medical advisory committee. We've been onboarding volunteers and community ambassadors. So community engagement's critical for advocacy, but why? And how does it look, and by who? Community engagement and advocacy can be something you do alone, can be something you do with others, or something you do for others. It can encompass all of this and more, and it can change over time. Community engagement in formal advocacy, especially at a national government level, can exponentially maximise the impact of it. It increases the voice of the community represented, making it louder and difficult not to hear or be heard by those you're advocating to. It builds effective narratives, driving the desired change and shaping the systemic improvements that you seek to see all at the same time. Community engagement provides transparency for policymakers, strengthens relationships, and in turn influences the outcomes positively. Community engagement comes in many forms. It can be sharing of first-person stories and narratives, like Joe spoke about before me. There's also community engagement in co-design processes. And this is the meaningful, non-tokenistic inclusion of the lived voice, experience and perspective in designing services and guidelines, for example, for particular groups of patients like ours. An example here has been ctDNA's involvement in the co-design and development of key pages for heritable connective tissue disorders and soon to be published Ehlers-Danlos syndrome with Rare Voices Australia for the RARE portal, which is a nationally, federally funded deliverable of our National Strategic Action Plan for Rare Diseases. Community engagement is the inclusion of the community's lived experience in patient journey mapping for better experiential outcomes and workflows in hospital systems, for example, in horizon scanning and health technology assessments that work to increase access to medications, technology and devices through public means, and in clinical trials, research and patient registries. Is the lived experience gained from community engagement in shaping those government-level discussions that I spoke of previously and ensuring the community voice informs high-level responses to parliamentary inquiries, such as ctDNA submitted for the Victorian Women's Pain Inquiry last year. Community engagement is all of this and more. Sorry, I'm conscious of time. We've gone way over. Okay. So who is it? Well, we can all be involved in community engagement. We can all be advocates. We are all advocates. We can all lend our voice, our experience and our perspectives to advocate for change. This can be done privately or publicly, quietly or loudly. There really is no limits to community engagement and how it can look or who it can be done by. Community engagement can be an interplay between patients and carers, with healthcare professionals, patients and carers, with academic researchers, or anything in between. It can involve stakeholders such as MPs, health agency delegates and more. As is the case in our community, often individuals hold many stakeholder roles, being patients, carers and/or researchers or healthcare professionals themselves, as you've seen on our panel today and earlier also. So, getting close to finishing. A quote I recall being shared during the very first Society Echo series I completed on becoming a patient advocate back when I was diagnosed in 2019 from the Lorax still rings true to me today. Unless someone like you cares a whole awful lot, nothing is going to get better. It's not. The crux of it being that we're all here because we care a whole awful lot about the community we're involved in, the community we're a part of, and community engagement. And here is a photo of our first ambassadors, the Jones family, who have lived experience with vascular Ehlers-Danlos syndrome. Thank you.
Thank you. For the sake of time issues, I'm going to echo. Just going to very quickly flick through the last couple of sections, just covering the very most important points, and then we have the question time. So, advocating for the best medical care, there are important things to realise. Firstly, illness is real. You need to empower yourself with knowledge. You need to get an official diagnosis of all comorbidities, not just EDS. You need to establish a trusted multidisciplinary care team, and some of that's going to even happen here while you're here. Remember, absence of evidence is not evidence of absence. It's probably the most important point in this session. Keep records. It's your body. It's your information. I don't care if you bring in a file this big when you come to see me. That's fine. Its records are important. Plan ahead to help minimize the negative experiences, and speak up. That takes courage, but don't be afraid. It's your body or the body of your child or relative that you're helping. And how to make a complaint. Here we just have the most important thing is keep complaints separate from medical records. They should not affect your treatment. Oftentimes they may, but they need to not. And these are various places that we can look for help. So we're just now going to go and sit down and have some question time. Right. Still alive. Excellent. So, from the audience, and that have come through, how do people with multiple issues manage all the different health professionals? I'm finding it very overwhelming to see all my specialists. That's a really, really good question. So, we've got a lot of you who can help answer. I'm just going to ask for 1 or 2 sentences from each of you. 1 or 2 sentence answers.
So how can you manage all your different health professionals? I think encouraging them to communicate with each other, and that's unfortunately and sadly going to fall on you a lot of the time to do. Yeah.
Excellent answer.
Okay.
Sherri.
I think you end up with a pile of records this high. So I think the most important thing is to summarise it. Doctors don't have time to read a whole pile of things. Summarise it and to a condensed document, take that with you.
2 things. A lot of patients I work with have complex files this big. We're finding having QR codes on watches that allow access to your medical file is really helpful in emergency situations in particular. So as hospitals, doctors, in those situations, people can actually QR your medical history as much as you want. So that can be there. And in terms of the multiple team, communication important, but dealing with what's most important now, what's going to make a difference to my life now, this week, and prioritising around those multidisciplinary healthcare professionals and or doctors, because you can't tackle all of it at once. It's like eating an elephant, it's impossible.
I like having patients who have a summary brought in. Bring in the whole file, but also bring in a summary, 1 or 2 page summary of what's going on, and again highlight the most important thing that they want dealt with that day. There are a whole lot of things that need to be dealt with, but we can't always deal with them all at one time.
I think keeping all of your doctors up to date with what is happening with you, and then yes, once again, just focusing on the immediate issue that you need them to look into.
And the other thing I would add is that we manage it. We keep a good overview ourselves. We don't expect it to just happen.
From a parent perspective is planning appointments well ahead. I mean, with such a big team, making sure that it's getting the care across multiple disciplines. So we will often book appointments 6 months in advance to make sure that it's all spaced out, but still getting the care that they need. And obviously, as I echo what Janna has said about getting the team to communicate with each other as best as possible, but I think also that forward planning of, quarterly team meetings, trying to make sure that people have got time in their calendars to meet all together.
Pardon me. For me, I think probably asking a couple of questions before going in to see specialists about, are you going to end up getting a request for a blood test or some kind of other scan before you head in there, so that way you don't have to go back again and again and bounce between different specialists. It can just help reduce the number of touch points that you have. Also, if you've got gaps between some of the specialists, and particularly some of them you might not revisit every year, it might be 10 years in between when you see them, keep a copy of your own records, because legally a lot of the practices won't retain full details. They'll keep some of it, but they might not have all your associated pathology. So just keeping a copy of those, particularly not the regular specialists, and asking for what info you need.
Yeah, I would echo just getting copies of absolutely everything and keeping that ordered in an amazing sort of filing system, but also having your support networks around you. And if you are working, just for your employer to really understand that you will need time for those appointments and you can't control when those appointments will land.
All excellent excellent answers. There's a question here, mainly for those of us who are on the treating side rather than the recipient side. With a limited number of clinicians aware of HSD and EDS, how do we clinicians protect ourselves from burning out so that we can advocate and treat clients long term? I know that question's partly directed at me.
Directed at all.
And I have a fantastic practice manager. She's not allowed to retire. And she helps a lot with the processes and coordination of the patients and care so that I don't burn out. And I've had to physically restrict the number of clinics I do a week. And that's not easy when you've got 500 patients waiting for their first consultation. It's not easy at all. So it is hard. Pauline, you're as a...
So I think because for exactly the same reason, and I'm in Adelaide, South Australia, where we have even more limited resources than the Eastern Seaboard. I've sort of even moved my practice into people knowing that they're on a waiting list and they're being triaged, because there's no way I'm going to be able to see them. There's the waiting list, which is extremely sad, but it is inevitable. I'm moving myself into a different space where I know I can provide more information and create that advocacy and support through education. And so that's where I'm headed myself personally, because I also scored long COVID along the way. And so that is probably the best use of my knowledge and skills, is to move into a different space, but pacing yourself. And like, for instance, many of us were talking about this previously, being at these conferences is so essential, being on EDS Echo is so essential, but pacing ourselves so that we have time off afterwards and time off beforehand, and giving ourselves, letting go of the guilt and shame that we can't see everybody. There is no way I'm going to get to all 300 people on my waiting list, unfortunately, but that is it.
Can I jump, in a little bit? I'd say also supporting the local formal groups, like CTD&A, who are having the important high-level national government discussions to try and change the system to improve things systemically, which will lighten the burden for everybody. Yeah. Increasing that workforce, from a different means, looking beyond, the usual mechanisms. Yeah.
Absolutely. And Jacqui, do you have a...
I also have an amazing practice manager who keeps me well in check. And I've had to come to the point, like Pauline said, of not feeling guilty for the wait list, and because it's also, I love what I do, I'm so passionate, I want to help everybody, but I've realised that I can't. But we're also the core centres and networks of excellence have been absolutely amazing. I'm co-lead and have an amazing team, and just that networking and growing that interest for so many more people, and love working and being a part of the Australasian EDS Echo, where we can train and get so many more people passionate in this space.
Excellent. How do you navigate one specialist denying a diagnosis of another in your care team? This is a really important question. I'm going to have each of you answer this one.
I'd say, without being too blunt, cut your losses and move on, potentially. Yeah. If you've got the means to do that, obviously there's a lot of privilege in being able to do that and having that choice. Yeah. It depends, I suppose, whether you're being seen through the public or private system, and what amount of autonomy you have in who you can see and how. Yeah. But putting in a complaint, asking for a second opinion from a colleague of theirs, it's a complicated question.
It's not easy. Sherri.
I have to say that most of our help came from private specialists, and we actually had to stay away from public hospitals for a while. So finding the right doctors is the most important thing, and that's the question we get asked the most from the support group is, which doctor should I see? And I have to say also, one of the specialists that we saw, when my daughter first met him, first thing she says, I hate him, oh, never going back. But he turned out to be one of her best specialists. So you have to sometimes just be patient and get to know that doctor and give it some time. But if it's not good, move on.
I think that is the benefit of having the EDS Society's health professional list as well, which is on their website, and you can see via state and via specialty who may be able to work with you. I know each and every state actually has an EDS or Ehlers-Danlos or chronic fatigue type syndrome Facebook support group page. People in there are actually very passionate often on those pages, and you will get lots of really good information about who is worth your time and money seeing. And who will not do more invalidation and more damage. So once again, if you can move on, and there are other people out there you're able to see. Also the benefit in this country of telehealth and telemedicine, both nationally and internationally, is, I can't underscore how important that is in being able to help each other as health professionals, but also for patients to be able to access other health professionals interstate and around the country and around the world.
My approach, one of many, is for the person who's denying it, I say, what evidence do you have to back up your statement? Because they don't actually have the evidence to back up their statements, which is unfortunate and frustrating, and many times they have what we call GAS, God Almighty syndrome. However, we have to still work with them, and so we still have to be polite while asking, what's your evidence for your statement? And then if they're still being frustrating, we move on to look for those who are willing to help. And unfortunately, it means that those who are willing to help tend to get overloaded, like we do. And I'm really sorry about that. For those of you who are out here who I have loaded, I'm really sorry, but it's because you're willing to help. So thank you. Jemima.
Often it's because they're refusing to talk to the professional who made their diagnosis. They're just looking at in your file and they're coming up with their own conclusion. So I think asking them to seek more professional advice, or if you have the possibility to explore other options for possibly a different doctor.
As Jemima said, I think you might get a number of different opinions. I've sought medical care for my children in New Zealand and in the UK and in Singapore, and got a lot of different opinions. And then I think sometimes you need to just go with the one that fits best for you and your family specifically. And then the other thing I would say would be that sometimes you know what you need, and sometimes you have to coat it with a little bit of honey to get what you need, or show the doctors what they're looking for so that you can get the test, or the, if you're in the public system. So you can get what you need for your child, no matter what it's taking.
And sometimes it's even, if you have to take in a research article or something like that, that's the links that sometimes we have to go to. But yeah, getting a second opinion, talking to others. I know what we love doing in our network of excellence is, because we've got, we're all multidisciplinary, from gastroenterologist, dietitian, EP, doctor, psych, etc. We've got that ability for people to reach out to us individually as a network of excellence to provide that information, because we're nationwide, but there is also, as Pauline said, the Ehlers-Danlos Society directory as well.
I would say seeking a second opinion is always a really big one. I did a lot of bouncing between different referrals and different diagnoses that weren't necessarily correct, and finding empathy and the knowledge in the same person can be a little bit hard, and again, trying to find that availability of those people to get in and see them is always the challenge. But having that second opinion and coming in with some peer-reviewed medical research, not just something off of Google, peer-reviewed medical research, hands down, will be more convincing for a conversation to try and challenge some of maybe the preconceptions you've experienced with a specialist.
It all depends on my mood on the day. Sometimes I'll stare them down and have that battle, and other times I will just cut my losses and move on, and definitely start with the EDS Society directory if we have that privilege to do so.
Wonderful. Thank you very much. Our time is now up. It is now lunchtime, and if Lara would like to give a little talk about what's coming up next, but just before you do, I want to say thank you very much to everyone here on the panel. Thank you everybody for submitting your questions. Sorry that we didn't answer so many of them, but they're really good questions. Thank you all.